Cushing's syndrome refers to a state or any state of glucocorticoid excess where whether it's endogenous or exogenous. Common causes include chronic steroid therapy, adrenal tumors, pituitary adenomas, and ectopic ACTH producing tumors. Pseudo-Cushing's occurs in alcoholism or severe stress states, so accurate diagnoses requires careful interpretation of labs. In Cushing's hypercortisolism, it specifically refers to a pituitary adenoma, Cushing's disease, producing excess ACTH, versus Cushing's syndrome includes any cause or all causes of cortisol excess. It's important to be able to differentiate the two with hypercortisolism because management will differ significantly. If we have a disease with a pituitary tumor, that can require surgery, whereas an adrenal tumor or even exogenous steroid use requires more targeted interventions. And this is just showing where our pituitary gland is and kind of where it sits anatomically in the body. We looked already that with some of the body's responses to cortisol excess, but chronic cortisol excess leads to elevated blood glucose, muscle wasting, osteoporosis, thinner skin, and easy bruising, and this is due to protein catabolism. It also can cause sodium retention, which then can lead to hypertension, as well as hypokalemia, because cortisol can activate mineralocorticoid receptors at higher levels. It can bind to those receptors. Immune suppression will lead to increased susceptibility to infections, and this is kind of showing you the systemic impact of cortisol excess. Clinically, you can see signs like central obesity or adiposity, facial plethora, purple striae, myopathies, glucose intolerance, even hirsutism or acne, menstrual irregularities, and bruising that occurs easily or without cause. Psychologically, patients can present with mood changes or cognitive impairment, and these features are relatively insidious. They develop gradually over time, so recognizing a pattern is really key to a timely diagnosis. Basic labs in Cushing's may show leukocytosis with low lymphocytes and eosinophils due to cortisol's effects on immune cells. A metabolic panel may reveal hyperglycemia, hypokalemia, hypernatremia from cortisol's mineralocorticoid-like activity. Thyroid studies also can be abnormal. It may show a slightly low T3 or TSH because cortisol does suppress the hypothalamic TRH and pituitary TSH release. And these labs can help support the diagnosis, but these labs aren't diagnostic on their own. First-line tests often include urinary free cortisol, overnight low-dose dexamethasone suppression testing, and late-night salivary cortisol, as these tests can assess either cortisol production over time or the loss of normal circadian rhythm. Patients must have multiple and progressive clinical features before testing, and if an initial test is abnormal, they should undergo confirmatory testing and then also be evaluated by an endocrinologist. Urinary free cortisol measures cortisol secretion throughout the day and is useful because it captures total free cortisol, not bound to CpG. However, results can be normal in patients with cyclic or early Cushing's, so multiple collections are often needed, which can be really challenging for a patient. Renal impairment also could falsely lower levels, and this test is best when cortisol is consistently elevated rather than episodically elevated. Healthy individuals, as we've discussed, have a clear circadian cortisol rhythm that peaks in the morning and falls at night, but loss of this pattern can suggest Cushing's syndrome. A midnight cortisol above 7.5 is highly suspicious. However, this test is harder to perform due to the need of nocturnal blood draws, which is not always available, especially outside of a hospital setting, as well as estrogen therapy can falsely elevate serum cortisol via increased CBG. Salivary cortisol reflects free cortisol and is independent of saliva production, and it's easy to collect at home. This makes it a really good screening tool. Midnight salivary cortisol is particularly helpful because patients with Cushing's lose the normal nighttime suppression. This test avoids any CBG-related confounders that we see in serum cortisol testing. This is showing us kind of our typical diurnal salivary data. giving us a picture of looking at kind of our normal versus Cushing syndrome, and versus ruling out Cushing syndrome here for kind of our diurnal salivary testing. I guess the only piece I'd like to note here is just the sensitivity and specificity of a late night salivary cortisol and how we shouldn't just sleep on salivary testing just because it's not something that we do all the time. Nearly all patients with Cushing's had elevated values of our midnight sal or late night salivary cortisol, while almost all healthy or pseudo Cushing's patients had normal results. And so this is why it is a reliable screening tool, especially in an outpatient clinical setting. In an overnight dexamethasone suppression test, 1 milligram of dexamethasone is taken at midnight, and cortisol is then measured at 8 a.m. because dexamethasone should suppress ACTH and therefore should suppress cortisol in a healthy person. In Cushing's, however, cortisol remains elevated due to impaired negative feedback. Cushing's disease, the pituitary form, may show partial suppression and requires a high dose of dexamethasone to really differentiate. And this is just showing a diagram illustrating the difference between a normal response and a Cushing's disease response to this test. In healthy individuals, dexamethasone will shut down ACTH and lower cortisol, but in Cushing's disease, the pituitary resists suppression, maintaining elevated ACTH and cortisol, which this physiology allows us to determine whether hypercortisolism is ACTH dependent. When we come back, we will talk about Addison's disease, kind of the opposite in our adrenal gland conditions.